Yes, thank you for the invitation and for the introduction. I appreciate it very much. And Dr. Morris, thank you so much also for your comments. I'm glad I'm seen as a good friend of this program, because I feel that way. And Agent Fu Berman and I go quite a ways back. Listening to my introduction and hearing the dates is very interesting. You know, for me, those dates are all very, they're just normal, you know, years. I think for the students, it's like, really, people were around back then? And it's like, yes, it wasn't so long ago, really, it seems. Anyway, so let me start sharing my screen and see here. All right. So yeah, so I am, my goal, I'm going to try to do this. Let me see if I can get my timer going here in 40 minutes. And so it's going to be a little bit of a challenge. But what my goal is today is I want to introduce you to a topic that I think is really fascinating and potentially very important. And to do this, I want to do this by asking a broad-ranging question. When it's one I believe is not well explored and should be the subject of more dialogue and research. And the results of this research may yield significant benefits to society and science. Again, these are my beliefs. Everything I'm going to be talking about is sort of a reflection of my own personal belief, as opposed to, you know, some official position of the National Cancer Institute or NIH. So some aspects of the complexity of this issue, the issue that I'm talking about is the interaction between allopathic medicine, which, you know, is, you could just read it any way you want. So some people will call it Western medicine or biomedicine. So just the things that, you know, we're all familiar with when we go to see our physician or into a hospital, and the complementary and alternative medicine or traditional medical system. So that's the issue, is how they interact. So I want to use some examples from the medical literature and some from my own personal experience to ask this question: can allopathic and non-allopathic practitioners effectively collaborate in the form of integrative medicine? I don't intend to answer this question, but I want to see if I can interest you in the question. So now I need to figure out how to advance my slide. Okay. Okay, so I want to first give you my perspective, which is, because I think it's important for you to know. I mean, you know a little bit, you heard something about it. So I'll just briefly, you know, because the things I'm going to tell you come about from how it is that I see this field. I am a physician, and I'm a medical oncologist, as you heard. I don't practice complementary and alternative medicine. I practice medical oncology. And so my perspective on this field is largely, you know, from where I sit in the National Cancer Institute. So I'll give you that perspective. I'll briefly talk about CAM history in the United States. Really, it's probably even, I feel a little that I'm not going to do that any real justice, but I just want to make an initial comment about it. Then NCI's history with complementary and alternative medicine, which I know more about. Research on CAM and cancer, and then start some comments about integrative oncology, and then hopefully do have a lot of time for questions. So, you know, I know many of you may not be from the area, but hopefully you have maybe at least awareness about NIH, our campus, which you see on the left. This is that's the clinical center of the National Institutes of Health. If you haven't been there, you ought to visit. I'm sure, you know, you'll find something fascinating there. On the right, you know, so there's 27 institutes in the National Institutes of Health. The National Cancer Institute is the largest, you know, by various numbers, you know, budget and so on. But anyway, and we are on that main campus too, you know, in the clinical center, but we also have another campus that's out by Shady Grove Hospital. So and that's where my office is. And so we basically, as you would imagine, you know, we coordinate a national research program on cancer, for every aspect of cancer, well, you know, virtually that you can think of. And so my office is the Office of Cancer Complementary and Alternative Medicine. And I'm the only director that so far has been of this office. And we are in the Division of Cancer Treatment and Diagnosis. And that's our mission there, which you can read. And basically, we wanted to have a mission that had us focus on cancer patients and doing something that would have, thinking about what to do with the research and the information production that would make an impact at the level of the patient. And so, that's how we strive to do. That's what we strive to do. So I want to, I guess, I'll use this slide really just to encourage those of you that have an interest in medicine to think about the history of medicine. And I really, that's the primary aspect of what I want this. I mean, I'll say something about, the conflicts between systems of medicine and so on. But I don't know. I mean, as I recall way back in the dark ages when I was in medical school or whatever, that we got taught a little bit of history of medicine. But I think it's not, we don't have a really, vibrant sense of it. What this is a depiction of, this comes from 1834, I think it is, the first edition of a magazine called the Thomasonian. And what it is a depiction of, the Thomasonians were, these were practitioners of a system of herbal medicine in the United States. And that was prevalent in the 1800s. And, it depicts really sort of a conflict of philosophies and approaches between the Thomasonians on the right, where you see the gentleman that's helping the patient up out of the slough of disease, having him rise up through the steps of common sense, as opposed to the physician of allopathic medicine who has the club, who wants to reduce the patient, wants to essentially attack the disease and beat it out of them. So it is, this idea of these systems not getting along is not unique to the Thomasonians in allopathic medicine, but it's just to give you a sense of how far back debates have gone back and forth between systems of medicine in the United States. And I think we lose track of it in modern days. So, and just to say that particular chapter I found very interesting, the history of complementary and alternative medicine in that book. It's a fascinating and well-written and brief chapter. I think you would enjoy reading it. So the National Cancer Institute has been around since 1937, I believe. We're we even predate the National Institutes of Health. But anyway, so we've been dealing with CAM issues in one way or another for a long time. And the first two entries there, Gerson and Hoxsey, these are approaches from that even still exist. Gerson therapy is, you can even find elements of it still in practice in Mexico and in clinics, and and people in the United States that would refer you to clinics down there. And Hoxsey's a herbal approach. And NCI looked at some cases of those patients treated with those approaches in early years. Laetrile people may know as so-called vitamin B17. It's not a vitamin, but people use that term. And it rose to significant interest in the United States to the degree that the National Cancer Institute supported phase 2 clinical trials for it. That was negative, that trial. Intravenous vitamin C, maybe people may not know too much today about how prevalent that was in the 70s and the 80s, and even currently there's a lot of interest in the use of intravenous vitamin C for the treatment of cancer. So NCI has been involved in supporting trials of that. And then just hydrazine sulfate is another just example of things that NCI was involved in supporting over the years. Congress has gotten involved in this issue and is responsible for a lot of what we're doing at NIH on complementary and alternative medicine research. And one thing that was done on the cancer side in 1990 was published here was the Office of Technology Assessment. That's what OTA means. And this was a congressional office that did a very extensive review of unconventional cancer therapies in the US and published this report. And it just reflects the societal interest in this topic, specifically on the cancer side. And from that, one of the things, that they recommended from that report was that NCI do actually more work looking at what cases existed of patients treated with unconventional cancer therapies and try to identify those that might have some, utility. So this led to a more formalized review of case series, and I give you two two time periods. One was the right after the OTA report, in which a couple of examples, which I'm going to talk about in a minute, of unconventional approaches were looked at in case series. And then when my office started in 98, we took over the review of this, and we've subsequently looked at several others. I should have mentioned earlier that everything I talk about, this included, it could be the subject of its own talk. There's a lot of history here. There's a lot of challenges in doing this kind of work. It doesn't do it service actually just to touch on it, but I'm using it just to give you a sense of, the level of activity and interest that there has been on this topic. Nothing here, if I can't unfortunately point to any of these things to say that the case series showed positive effects. That's not really why we do it. We do it to look to see if there's something warranting future research. But a lot of people think of that when you do a case series, you might be able to identify whether or not a therapy is effective, but that's not possible. I mean, these are not controlled experiments. These are not clinical trials. These are examples of cases. They may even be manufactured cases. We don't even know. So what the best you can do is to get information, look at it as thoroughly as you can about cases, and decide, okay, is there enough here to go forward with some prospective investigation? That's some reason of doing it. You cannot determine if a therapy is effective by looking at selected best cases. But I do believe that this is a worthwhile screening process for identifying things to invest more time and effort into. So as you remember from before, there was a mention of anti-neoplastins. Okay, it's the clinical trial. This is the report of that on the left. And this was a clinical trial done at Mayo Clinic. Again, each of these things actually could be its own talk, because this is a very, very interesting and situation. If you look at the authors on this paper, you'll see Mayo Clinic authors like Jan Bruckner. I don't know if I have my pointer. I hope you can see that. So Mayo Clinic authors, NCI authors, Eddie Reed and William Fig, Doug Fig. And but what you don't see there is the person who developed anti-neoplastins. Anti-neoplastins, these are compounds that Dr. Stanislav Brzezinski, who you see on the right side, is the author of this editorial, or excuse me, letter to the editor. He's the developer of anti-neoplastins. And so the story here is that he agreed to work with NCI and Mayo Clinic to do a prospective clinical trial investigation of the effectiveness of this approach of these compounds. And I won't go into the detail of what they are. I don't want to get bogged down into it, but they are, so this is his discovery. And he had been practicing this for many, many years at the time. He had many cases and they were reviewed. And if you read through it, you'll just see, that a small number of patients, only 9, were treated in this study. And that's a whole issue in of itself. There were no patients demonstrated tumor. These are recurrent glioblastomas, actually. This is the most aggressive brain tumor that there is, okay? And it says gliomas, but I'm pretty sure they're all glioblastomas. No patient demonstrated tumor regression. And that's the report in the Mayo Clinic. Okay, in the same journal, Dr. Brzezinski writes to complain that this was not done appropriately. The issues that were, the things that were done to either sabotage or just not, that caused this not to come out the proper way. And you can read the details. I don't want to go into them in depth. Because the story is that an attempted collaboration was done, and actual initial collaboration happened. Willingness on the side of a practitioner to work with the allopathic medicine research community to make something happen. It goes through to fruition, at least in part. The goal was initially to accrue many more than 9 patients, but again, that's a separate issue. And then it devolves. It devolves into a situation in which there's unhappiness, and that leads to conflict, and the practitioner is not willing to be on the paper that involves his own work. So Wayne Jonas, who was he was one of the early directors of the Office of Alternative Medicine. He was involved in some of this work, in overseeing some of it. And he and another researcher decided to write about this idea of what happens, or what happened in this situation. Why was there conflict, and how can you manage this kind of situation? And it is, I think, something that needs to be done more, although there are not that many examples of this kind of thing. But anyway, that's again, a full story in and of itself. A second example of this is, as I mentioned, Gerson therapy. Well, anyway, there's a similar thing to Gerson therapy that was done by a dentist named William Kelly. William Kelly developed an approach that used pancreatic proteolytic enzymes in the treatment of cancer. And a physician actually, by the name of Nicholas Gonzalez, got interested in this as well. And he turned it into his own personal practice in New York City, as he had a vibrant practice there, utilizing this approach to the treatment of cancer with proteolytic enzymes. And it was Gonzalez actually that got NCI to look at some of his cases and to determine if prospective research was warranted. And the decision was made to go forward with it. Again, it's a very long story. At least maybe I just don't know how to tell short stories, but it's a very interesting one. And this led to support by Columbia University. So again, on this paper, you see an author, you need a couple authors from Columbia University, John Chabot, Dr. Tsai, the statistician, Karen Antman, who was the head of the Cancer Institute there at Columbia. Victor, all of these are Columbia authors. So the one name you don't see is Nicholas Gonzalez. So, and this goes on to tell the story of this study. attempt to use pancreatic enzymes to treat pancreatic cancer. And again, based on the history of these, of some case reports showing the potential effectiveness of this, the potential effectiveness of this. So ultimately, if you look at this non-randomized study, happy to explain, or talk about this in depth, why it is that. But anyway, it was a comparison against chemotherapy. And as many people may know, pancreatic cancer is, particularly when this was done, not hugely effective against, chemotherapy is not hugely effective against pancreatic cancer. So this is the survival curve in blue of the patients on chemotherapy, and the yellow is the survival curve of the patients on the pancreatic enzyme therapy. And again, so this does not certainly show any improvement, and certainly it shows a substantial decrement with a 14-month median survival for the chemotherapy and about a 4.3 months median survival for the pancreatic enzymes. So I know I already can feel that I'm investing a lot of time in a lot of these stories, but so Dr. Gonzalez, not on the paper that I just showed you. He writes his own paper. He writes, excuse me, an article in this Townsend letter. Townsend letter is a complementary and alternative medicine type of a magazine, and in which he says some thoughts about scientific bias. Well, what he's saying is that he's explaining the problems from his viewpoint. What happened in that research? Why did it go? Why didn't it show what it should have shown by his understanding, which is that his therapy was at least better than what was shown there, and probably better than chemotherapy. And even a 4-page article in that journal was not enough, so he wrote a 616-page book about it, and in which I mentioned not favorably. I want to show this example though, because I'm only aware of one example in which you have the practitioner on the paper in a negative study. So this is a physician. He's actually well, he's dead now, but he was a psychiatrist who promoted the use of megadoses of vitamins and minerals for treatment of cancer. This was in Canada, and he agreed to work with a group of allopathic physicians and researchers because he believed in his approach, and he believed that it was going to demonstrate effectiveness. And this is not by itself. This is actually, patients got conventional therapy as well as these minerals, but if you can see, and it's hard to tell, but at least from these curves, the top curve is always both instances the control, so the patients that didn't get this, and then the bottom is the cases that did get the megadose vitamins in that. So certainly there's no advantage to using that in this one study. I just want to say that this physician decided that he would sign on to it. He would sign off on this. That at least the research in he didn't denigrate it. He said that so that is something to learn from. I'd say. All right, so let's see, and I'm at 17 minutes left. So I think people must generally know that there's a lot of use of complementary and alternative medicine among cancer patients. I think I may even skip through this because it's not really going to tell us a whole lot of new things. I'll just say that, yeah, it's probably best to not invest the effort in this, but it is some work that we did ourselves. And maybe if there's any interest, I could, raise it in a question or something like that. But what I want to say is that, although we're interested personally or as a program in identifying approaches that might warrant prospective research, obviously we're not of the view that everything that is in the CAM world is of value. And there are certainly examples of things that are published examples of interactions or negative situations in which patients that pursued on the left a complementary, or excuse me, I should say an alternative approach that which led to a situation in which the patient did very poorly and was not able to go on to therapy, and the patient actually died. And this is a problem that people that can be diverted into ineffective therapies, certainly. And then the one on the right is a situation in which, patient is using a therapy, doesn't disclose it to their physician, and ultimately, as they start they're following this patient, they're using a therapy that they expect to be effective, and that is frequently effective, but they see a progression of disease, and they fortunately do a better history of the patient, and the patient then says, well, I am using an herbal approach, and they ask the patient to stop. So the progression that you see in these CT scans, or if you can just imagine, I think maybe you don't look at a lot of CT scans, but anyway, you can see that perhaps from A to B, there's some worsening, B to C, there's some improvement. So B is when they ask the patient to stop, because they were even considering stopping their medication, right? And because they thought it wasn't working. Well, it wasn't, because apparently there's interaction with this herbal medicine. Once she stopped taking the herbal medicine, they started seeing the improvement, and then it can all continue to improve. So certainly we have to be very aware of the potential for that kind of thing to happen. So, and for integrative medicine to really be an evidence-based thing, that kind of work, needs to be, or work that actually documents clinical trials results and is built off that is critical. So quickly, I'll show you just some of the things that that our office's portfolio includes, just to give you some flavor, and then I'll move on to integrative medicine, I think. So this is just to say that, we have, this is a small, actually, set of examples from NCI's overall much larger complementary and alternative medicine research portfolio. But so many, various different projects, mostly preclinical, so laboratory type projects of, but some of them are clinical trials of natural products, and not just natural products like Taxol. So, I mean, you may know paclitaxel or many chemotherapeutic drugs are natural products, but these are generally things that are the ones that I'm highlighting here, or come from traditional medicines, or they're the kind of natural products that don't have the level of toxicity of or routinely of a chemotherapy. The third one is an example of an actual full herbal mixture. Okay, something that NCI, you would think that, well, you would think NCI, definitely they're going to look at isolated natural products. Maybe they might look at a specific herbal extract, but a complex herbal mixture of more than one herb, well, yes, there are some examples of it. And it has to get through, all of this is coming through the same kind of screen of that all grants go through for review committees, and the science has to be high quality. So these are natural products examples. The next one is, and I have some obstruction in my view, but I think this is the dietary, the diet section. I need to get more sophisticated in how to see my screen, but yeah, so again, you just to show you examples of kinds of diet interventions, single component interventions like fatty acids or amino acid type things, and what kinds of situations the research is being done. So this is the kind of research that could be used to develop integrative, evidence-based integrative medicine. And just more examples of this: calorie restriction, specific dietary amino acid restrictions, and so on, and various vitamin interventions and such. Okay, So international research activities, the reason to talk to them is now, to talk about them is to begin saying something about traditional medical systems. So just to point out that there are examples of therapies that are in common use now in the throughout the world that do have origins that come from traditional medical systems. Now, arsenic, very, very interesting compound, and utilized actually in not only in traditional Chinese medicine or in traditional Indian systems of medicine, but actually even in old Europe, there was some use of arsenic. And so, but if you ask, how did the use of arsenic in the treatment of acute promyelocytic leukemia come about? That comes about from China. And so this is, I think, a real example of an effective therapy that did find its way into common, allopathic medical practice that comes out of a traditional system of medicine. But I don't know how much it's really actually acknowledged. So what we've built over the past many years, a relationship with the China Academy for Chinese Medical Sciences. And that relationship is largely built around training of postdoctoral fellows. And this is just some pictures of some of them and a listing of some of their articles. What they've done is, so these are traditional Chinese medicine physicians who have generally PhDs also, and so lab experience, and that they have, we've identified a couple of laboratories in the intramural program at NCI that were open to having these postdocs. And they would come for generally 2 years. We may have had people slightly less than that, but it's generally 2, and this is out of the pre-COVID days. But, and work in the lab. And what they would often do is bring herbal approaches that they are using clinically and explore some of the aspects of the potential mechanism of action of these approaches in this laboratory work. So I should point out Joost Oppenheim, who's the head of, who passed recently, but was the head of the Laboratory of Molecular Immunoregulation. Much thanks to him for all of the support that he's given over many years. And and when I've asked him and other laboratory chiefs about their experience with these postdocs, they said they were very good, very well-trained scientists. Okay, India. So our most recent work has been with India. And the interest there is in all of the Indian medical systems, but Ayurveda is really where we sort of settled most of our efforts recently. So we have, as a result of that, the meeting that I just showed you the picture of, so 7 years ago now, was a couple-day meeting. This meeting was was actually quite a high-level meeting between it was sponsored by the Department of Health and Human Services, along with the Ministry of Ayush. The Ministry of Ayush in India is so they're a cabinet level, they're a ministry, and they deal with all the aspects of traditional medical systems in India. And so this came out of their interest in working with NIH, and NCI agreed to explore opportunities for collaboration. And this was the first thing we did, was to have this meeting. And that meeting was followed by a paper that we wrote. It just overviewed what it is that the kinds of things that are happening, and the kinds of suggestions for how this research, could be made to have a greater influence on Western science. A lot of this work is never, the work that is done by people in these areas are just, I think, they don't make their way into the journals that people read or the conferences that people go to, and the circles are just totally they are separate. They do not overlap very much. So following on to that, we have established a couple or a few very specific interactions that we hope to carry forward in the next few years with the Central Council for Research in Ayurvedic Sciences. And I'm still going slow, but one of them is cases of patients, case reviews, something like the Best Case Series program, trying to look at examples of really cancer patients treated with Ayurveda or Ayurvedic medicines and see what can be mined from that might lead to some research questions. We've suggested that they do a survey of integrative oncology in India. So what are the examples of Western medicine and Ayurveda working together in India? And so that is to start. And then they've asked for us to get involved in helping them do some research training of Ayurvedic clinicians and researchers to standards that are, equivalent to the Western standards. So I think India is a fascinating place, obviously, for many, many reasons. Their institutions, they have, maybe shouldn't call them hybrid institutions, but there are institutions like this one, Amrita University, that has a very high level, regular university that has with it an Ayurvedic medical school. I put the thing in the bottom there about the first robotic assisted DBS implantation for Parkinson's disease. I don't know if you all know, this uses a robotic system called ROSA. The ROSA system, so for intracranial, for neurosurgery, this hospital in Kerala, in Kochi, India, had this system actually maybe a year or so before Georgetown had their system. So I mean, they're very high level regular allopathic medicine, and they have Ayurvedic medicine going on as well. All right, so now in the last few minutes to talk about what is integrative medicine. I mean, I've been sort of saying integrative, but all right. So here's complementary or alternative medicine in cancer care, myths and realities. So this is an article from, so I guess it's 10 years back now, by two researchers that I respect, although I disagree with this article or aspects of the article. Gary Ding, consider even a friend, Barry Catholic knew for many years. So in the article, they talk about, says the term is CAM, complementary and alternative medicine, has been outdated and is no longer in common use. Says the term integrative medicine is fast replacing that of complementary and alternative medicine, or CAM. And complementary and alternative have different meanings and should not be connected by and. And the term integrative therapies accurately describes the complementary treatments being used in medical settings alongside conventional practices. And the term CAM is really rarely applied in legitimate settings. Okay, so that's their opinion. And so for me, I think this is not the way to talk about integrative medicine. I mean, integrative medicine, sort of saying, it's the same as CAM, but it's a better term. But they're not the same things. And for me, what we're trying to explore and why we use the term CAM is because CAM, although you can, if you don't like the term, you can come up with a better term, but integrative is not a replacement. It's a sociological situation. It is something that exists in the world. Now, you can say it shouldn't exist. Okay, that's your opinion, fine. But it's something that does exist and needs to be studied and understood. If you want to replace it with integrative medicine, that can be your mission in life. But to just sort of erase it as an entity is not probably possible. And it's not sensible and it's not scientific. With due respect to the people who feel differently. So integrative medicine and approach to the practice, excuse me, I like this definition, and its approach to the practice of medicine makes use of the best available evidence, taking into account, again, I'm sort of obstructed here, but anyway, the whole person, and then aspects of lifestyle and so on, and utilizes complementary and alternative approaches. I think this is a reasonable definition of integrative medicine. Sorry that this may be a little bit harder to read, but it's at the bottom here. This is the Society of Integrative Oncology's definition. Below here is a patient-centered, evidence-informed field of cancer care. I don't like that field thing, that utilizes mind and body practices, natural products, and so on. And you can look at the rest of that. I consider it a field like GI oncology or neuro-oncology or something, or even nutritional oncology. I guess it depends on how you want to define what a field is, but that's the part I don't go with on that. But NCI, so what's it look like in the integrative, what does integrative medicine look like academically in oncology? Well, so I want you at least to be aware that there are NCI designated cancer centers that have integrative oncology programs, and here are the three that are the most well known, and maybe still the three that are, really, the most, that only three that really fully exist. There's an academic organization called the Society of Integrative Oncology I just mentioned. They have an annual conference coming up this year. I'll be in Canada, where researchers from around the world, it is international, meet to talk about various issues related to this field, again, field, whatever you want to call it, to this approach to practice. And there's at least one journal that is actually, very specific to integrative cancer therapies. There are textbooks on the subject. These are some of the older versions of some of these textbooks, but anyway, they do exist, and written by, some of them written or edited by heads of some of the programs that I just mentioned. They've gone on to develop guidelines of practice. The Society of Integrative Oncology has, and this is an article that shows that the American Society of Clinical Oncology, ASCO, is endorsing these Society of Integrative Oncology clinical practice guidelines. So they think that that's the biggest organization in oncology in the world, is the American Society of Clinical Oncology. So these are some of the examples. This is some of the, so in those guidelines, this is what I won't go through all this. I just want to show you that they're trying to show you levels of evidence for the kinds of interventions and the situations in which they're used, and and grade them out in some kind of way. A is obviously just like your classes. So A's are good, and things lower than that are less good. And so so you see there are very few A's in this whole system. And the other thing you'll see is, if you look through it, all these clinical outcomes, these are all symptom, side effect, quality of life type outcomes. There aren't any guidelines about the use of a complementary approach or integrative approach, whatever you want to call it, that affects the survival or the response to therapy. So that side of integrative oncology is sort of, it's not yet gotten into the mainstream. So again, all these outcomes, fatigue, lymphedema, neuropathy, pain, none of them are about survival. The last thing, and then I love to hear some questions, is, okay, well, what does the literature look like about the dialogue between these systems? I've been saying that I want there to be this dialogue. So what's the evidence that is happening, or has it happened? Well, so we did I want to say that this is the work of Sophie King. Sophie is from your program, from the HAPPY program. She's been an intern working with me. It's been a great experience having her. And most recently, I asked her to try to explore this. So what's in the literature about a dialogue of some kind between systems of medicine? and we can find very, very little. This is from actually 3 different databases. That's all we can find. PubMed database, I'm sure you're familiar with, Embase, Scopus. We've looked, and there's so little literature that looks at this, and actually none of this actually looks at it in the way that I'm trying to promote that it happened. You see articles. The red ones are just ones in which you have both a CAM clinician that's involved in this article. These are basically survey type articles. These opinion articles from these clinicians, CAM clinicians and conventional clinicians. So you'll have articles of one or the other, but only 4 articles we can find in which the 2 are, their opinions of both are explored in the same article, and none of them are about a communication between these systems. So for me, this is something that needs to be done. People say, well, how do you know it needs to be done? Well, let me let you ask these questions as opposed to me ask myself questions, because I think that's the last thing that I want to say. Again, very happy to be involved in this, and I'm looking forward to any of your thoughts on this topic. Hope it's been a little bit interesting for you. I'll stop sharing.
Okay, Jeff, Dr. White, while our moderator gathers her, gets herself together to take over the question and answer, I just want to thank you again for being here, and really for your kind of enthusiastic and thoughtful approach in presenting what would often be kind of a contentious or territorial kind of talk. I think this is exactly the kind of approach that's going to get people to talk to each other. So Annie, I'll turn it back to you, and you can take over the Q&A.
Thank you, Dr. White, for your informative presentation. I have a question, actually. My question is, how do we encourage conventional Western medical practitioners to practice integrative medicine? And also you kept talking about bridging the 2 together. So what ways could we encourage that linkage between the 2?
Yeah, well, those are the right questions to ask. I think so the encouraging them to practice integrative medicine, I think it's the okay, I'll take it first. So for me, again, I don't promote it as something that is the integrative medicine thing. What I promote is the dialogue, which is the second part of your question, and that from that kind of interactions, which, so we have to get to that part, but from those kind of interactions, then real collaborative activities can happen that would develop an integrative approach to medical management. But right now, I think what happens is, to a large degree, is really, and it makes sense in the U.S. environment. You have the dominant medical culture, allopathic culture, and you have others that are really fairly peripheral, chiropractic or naturopathic or whomever else. And we have very, and within traditional Chinese medicine, only acupuncture, only that one little piece of it is sort of allowed in. And so there isn't this kind of dialogue. So I think you need that dialogue to build a really vibrant type of integrative medicine. That's first. So now back to okay, so how do you get people to have this dialogue? Well, you certainly have to introduce it to them in some kind of process that they can pick up on, and that they can get somewhat interested in. So at the level that we're doing now, and at the level in medical schools, I think it needs to start there, and then in the societies, the professional societies, to the extent to which, people that have dual training, and there are some few, or, if they can make their way into those circles, they can start having that kind of influence. And the research, as more research that builds up that can support the value of that kind of, those kinds of bringing together these systems, then people will pay more attention to it.
Thank you. And also, one of my classmates asked a question in the chat. He said, while young Chinese people feel that some ideas about traditional Chinese medicine lack a scientific basis, older and middle-aged Chinese people believe in this doctrine. So how can we better distinguish which are good theories and which need to be kept away from?
Yeah. So, I talk, when I get a chance to talk to young folks like the interns that, or not interns, they're postdocs that come over, right? And I remember I asked one of these are people that are generally, they're well, a little older than you, I guess. They're close, around 30 or so. And because I asked them, so you must have like friends. So you went the traditional Chinese medicine route. So, but you must have friends that went the MD route or whatever. How do you all relate? Is there something that how do they view you? Do they think that, oh, it's too bad that you had to go that way? I mean, you couldn't go to the real, medical school. So sorry for you. But, the woman I was talking to, this is a very intelligent woman. I mean, I'm sure that they wouldn't relate to her that way. So I think there are young folks that, are going, that are going after this as a preference, as opposed to, I mean, I have heard that, it is sort of a default for some people. I couldn't get into the medical school, so I end up going this way. But I don't think that's the way that it's happening for all of them. And like I said, the ones that are coming into these labs, they've been well received, and they've gone on. And they've gone back, and some of them have become leaders of research in the hospitals that they're from. So I think that the young folks, the few that do, commit to this kind of path, will start exploring this in a, scientific way, and they'll maybe change, the way that it's practiced, and bring more science to it.
Thank you.
Matt has a question.
Yeah, I was curious how we get the FDA to recognize like integrative medicine, and in order for it to be like regulated and prescribed and covered by insurance.
Mm-hmm. Yeah, so, right, and this is a very, when I was just in India, and I met with actually the FDA, the representatives there in the embassy, one of the things they wanted to talk about was that they get a lot of inquiries from companies that want to get, now this is, they want to get, their Ayurvedic products into US markets. So we'll just talk about products right now, and we'll get, if we can talk about integration, but at least at that level. So if you want to have access to certain specific, products, well, what a lot of them in India and China and so on, these companies, they want a new path to to drug indication, but that's not going to happen. I mean, there are is a possibility to have drug products that are not single molecule products, that we're used to, aspirins or whatever. There are these things, and but there are very, very few of them. And they're going to have to go through the same kind of quality control, the same kind of preclinical research for safety and so on, or some of it. And they're going to have to go through the same kind of clinical trials process. So there isn't going to be a very dramatically different path for those approaches. And I think in the US environment, in which the FDA is responsible for safety and efficacy evaluations. I mean, some countries, the efficacy piece is of less importance. They will provide, products that, for which the safety is, clearly identified. But in the US, I don't think we're getting away from that. It's going to have to be safety and efficacy. And yep, they're just going to have to follow the guidelines for the most part.
Another question I have is in terms of like the holistic approach to medicine that you talked about. I know like doctors of osteopathy, they tend to practice that more, but they're often looked down upon in the medical field. So when it comes to building this linkage, like, would you say that there needs to be more collaboration between the traditional side and like alternative medicine in terms of them, or like, how would you go about that?
So in the US, I mean, so definitely read that chapter or something like that to get a feel. It was really, I read it again recently, and then it was interesting seeing the conflict between chiropractors and osteopaths. And so, you know, they had as much, you know, problem with each other as they had with allopaths. And, but osteopaths in the United States at this point, to my understanding, is there's very little difference between osteopaths and MDs. I mean, they don't do very much manipulative. You know, you think of osteopath, that, you know, they do spinal manipulation, and that's what chiropractors do. In the US, I think not much of that happens. And, you know, there are osteopaths in all kind of postgraduate training programs. You know, there've been some, you know, they're in research programs, you know. So I don't know that there are huge barriers between osteopathy and allopathic medicine. I think that most of that's been broken down. You'll find osteopaths that practice the manipulation in some other countries, but less so in the US. But yeah, I mean, always I think, I mean, you know, again, it's when you have this interaction, I do believe deeply in the value of science, and that if you have an intervention for which you postulate it has a mechanism of action, and as you start exploring it, and so if manipulation has a mechanism of action for that explains the effects of this intervention, yes, you have to be willing to stand up to allopathic scientists or whatever, and explore it in the same kind of rigorous way that they would explore any kind of orthopedic intervention.
Thank you. Any more questions?
So I see Matt has a question, but after Matt, let's open it up to anyone who has questions.
My other question, I was curious, I understand that medication genetics can play an important role in oncology, and I wonder if you see them also having an important role in other fields.
Yes, sure. So metabolism of drugs. Yeah, absolutely. So right, so on the oncology side, you know, if you metabolize the drug in some kind of aberrant way, you know, it's generally, if you're unaware of this, it's not going to be good. And so yes, we do have we do explore now some specific metabolic some metabolism pathways for certain drugs, not routinely very much. But, you know, we do it, and sometimes you'll encounter patients that have, you know, an unexpectedly dramatic GI side effect from, you know, 5-fluorouracil or something like that. And that will prompt you to do this kind of evaluation. So I think we still have kind of a reactive, approach to genetics for metabolism. But yeah, I do think that I don't know the extent to which it's finding its way into other fields of medicine. It's just because, you know, in oncology, it's so dramatic. You know, we have toxic drugs, and they can be made either dramatically more toxic, or, you know, or you could see ineffectiveness because if something is, you know, metabolized away or whatever, or not even metabolized, you know, because we have drugs that are prodrugs. tamoxifen, for example, is a prodrug that's used in breast cancer management. But so if you can't change tamoxifen into endoxifen, the active compound, then tamoxifen is going to be useless for you. So yeah, I think that's why it has become more important in oncology. But yeah, you would expect the same kind of thing happening throughout medicine.
Are there questions from people outside of the HAPPY program? John?
Bingham.
Yes, hello. When I remember reading a survey about this, there was one number for cancer patients who used complementary and alternative medicine, and then there was another number for patients who use complementary and alternative medicine other than prayer.
Mm-hmm.
So I'm curious as to what your take on the role of religion is in these circumstances, because so many people, they take a spiritual turn very urgently when they get a bad diagnosis, and it can be very emotionally important to them, but it can also divert them away from other treatments or create unrealistic expectations. Very difficult subject. So I'm wondering what your take is on it.
Yeah, well, thank you. That's a good question. Yeah, for me, so the way that complementary and alternative medicine has often been categorized, the spiritual piece of it has been often put into the mind-body category. When I do talk about categories, I generally break it out as its own category, the religion and spiritual element. I think the reason why people look at it, in surveys, they want to separate it out is because there are, this is maybe the less concerning aspect of, it's except for what you're saying, there might be situations in which people are diverted by their spiritual beliefs. But I think it's sort of pretty separated from at least the natural products kind of piece and diet and those kind of other things that have, these kinds of mechanisms. So I do think it ought to be looked at by itself. And you also will see, like, if you lump it, if you put them all together and you look at what is the utility, what's the how frequently is CAM used? That's where you'll see, like, there's an example in the literature of a 94% of patients use complementary and alternative medicine. All right, but a large percentage of that is individual prayer. And it's not telling you, people that want to do these, that are doing that kind of survey research, that doesn't give you the right a feel for exactly what's going on, I think. And so but I do think it's important. I think it's under-researched. And I do think that the making interventions that do appropriately acknowledge people's religious and spiritual, the place where they are, is very important for their quality of life and symptom management.
So we're kind of running out of time, so I want to make sure that we get to Dr. Mitsuo Tomita, who has raised his hand quite a while ago. So,
Okay.
So thank you. So I guess I think the alternative complementary medicine is placebo effect. And I don't mean to say placebo effect is bad. People feel better when they're treated, when they're touched, when it's given by someone of authority or titles. If the pill is red versus whatever. So there's a lot of aspects of placebo effect. But again, I think we want treatments that are more than placebo. And again, a lot of these have certain risks. And again, in particular, the herbs. And I just mentioned again, recently came to my attention that turmeric got a lot of arsenic in it. And we used to use mercurochrome and merthiolate, which had mercury as a tincture, but we don't use that anymore because mercury is not good for you. But these alternative complementary medicines also have a detrimental environmental effect. And the loss of tigers and all sorts of things, all that stuff is driven by this complementary medicine stuff. Any comments about the placebo effect? Is a significant part of acupuncture with no consistent pattern of where you put needle. Anyway, let me stop at that.
No, good points. I mean, yeah, no, I understand what you're saying. And then even beyond into the effect on the environment. But yeah, and so I think we have I think placebo effect is throughout medicine, first of all, into the medicine that we do, unfortunately so, in a lot of ways. I mean, the patient physician interaction, if you want to call it placebo, you could call it something else, but there's a positive effect to that. But what I think in part what you're saying is really largely what you're saying is, how do you really tease apart the real specific effect of an intervention from this non-specific effect, and that's what research, good quality, controlled research is for. So that's 100%. If I haven't given that message clearly enough, it's 100% of the reason that I've been in NCI for 32 years, and that as opposed to some other place, it's this research is critical. It is the bias that things that seem somewhat maybe or less plausible because they're less familiar or whatever. That bias is where I'm would like to hammer at that a little bit. And I know that I have I might be considered to have a too liberal viewpoint on that, but it doesn't prevent me from really advocating for rigorous research. Now you could say, well, there are some things that's so implausible. Why would you even invest research into them? And that's where we can have arguments, but or disagreements or debates. Let's just call them debates. But now on acupuncture, there's some very good research that does look at susceptible people that are inclined to have acupuncture responses versus those that aren't, and trying to understand, well, what is it? Is there a way that you can actually screen for people that do have, more of a, now I'm talking about the specific effect of acupuncture as opposed to the placebo effect of acupuncture. There are even ways to explore that. So there, I think the more you dig into some of these things, you can actually find ways to do rigorous research that explores the placebo. The last thing I'll say about placebo is that a friend, well, I call him a friend, I guess, of mine who's at Harvard, who does placebo research, actually does some open label placebo research. I don't understand this. Maybe I shouldn't mention it because I don't really understand it. But he does research in which he tells people that they're going to get a placebo, and they can still have a clinical effect from it. It's very strange. So there's a lot that we don't understand about placebo. There's some good brain imaging work that's being done with placebo. So anyway, that's all I guess I can say about that.
Since that's all for the questions, thank you, Dr. White, again for your presentation and for your Q&A discussion. It was very informative.
Well, thank you, and I appreciate you going a little long for me. And I hope I at least stimulated your thinking about this topic. There are a lot of things to think about here. But anyway, wish you all the best of luck in your studies. And again, appreciate the opportunity.
Thank you, Dr. White.